Hello, everyone, and welcome to today's live broadcast, Monitoring Pain Management Medications in Pregnancy and the Neonate, presented by Gwen McMillin, PhD, Medical Director, Toxicology and Pharmacogenetics, ARUP Laboratories. I am Christina Mahalik of Laboratories, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by Laboratories. Laboratories is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I'd like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want, anytime you want during the presentation. Just click on the green Q&A button located in the lower left of the presentation window and type your question into the box that appears on the screen. We'll answer as many questions as we have time for at the end of the presentation. Also, please notice that you will be viewing the presentation in the slide window. To enlarge the window, just click on the screen icon located on the lower right. If you have trouble seeing or hearing the presentation, please click on the support button at the top right of the presentation window or use the Q&A button to let us know that you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the button in the bottom left corner and follow the process to obtain your credits. Now, please join me in welcoming Dr. McMillin. I will now turn the presentation over to her. Dr. McMillin, the floor is yours.
Well, hello, and thank you for joining me. So, as mentioned, I'm going to be talking about monitoring pain management medications in pregnancy and the neonate, which is important because pregnancy is not exempt from both medical and social needs related to the management of acute pain, chronic pain, substance use disorders, and addiction. For a woman that is interested in becoming pregnant and also is being treated for chronic pain, it's important to offer preconception counseling to discuss therapeutic options, both pharmacological and non-pharmacological. In the United States, it's estimated by the Opioid Prescription Claims Survey that 14% of women receive at least one dose of an opioid during their pregnancy. And it might be surprising to know that opioid misuse and abuse during pregnancy has increased. In fact, women now receive more opioid prescriptions than men, and heroin use has increased 100% among women between the years of 2002 and 2013, compared with a 50% increase among men. And in fact, every 3 minutes it's estimated that a woman seeks emergency care related to prescription opioid misuse. And deaths from prescription among women have increased more than 400% between the years of 1999 and 2010, compared with 237% increase in men. So chronic opioid use is a problem for women in pregnancy. There are many, many concerns, including acute withdrawal, which could increase the risk of miscarriage, placental abruption, low birth weight, preterm labor, and stillbirth. But we recognize that there are some pain conditions that respond best to opioid therapy, so opioids may be indicated. And if so, they need to be titrated to provide adequate therapeutic response and also prevent acute withdrawal. In cases of addiction, considering opioid substitution with drugs such as methadone or buprenorphine is appropriate. And these drugs have been shown to help decrease high-risk maternal activities, reduce exposure to the unborn child, and reduce the risk of withdrawal symptoms in both mother and the infant. When we talk about withdrawals observed in the infant, we're characteristically talking about neonatal abstinence syndrome, or NAS. Nationally, the CDC has reported that in 2012, approximately one infant with NAS was born every 25 minutes. In their Morbidity and Mortality Weekly Report that was published in August of 2016, they reported data for 28 states for which the incidence of NAS was publicly available. And that a schematic of that data is shown on the next slide. So you can see that the geographical variability is pretty intense. The states that have experienced some of the most dramatic increases in the incidence of NAS include Vermont, Virginia, and Maine. Overall, the incidence has increased over 300% since 1999. So as a consequence, several health systems are now developing programs for pregnant women with opioid substance abuse problems or addiction to offer programs that provide comprehensive support for managing opioid addiction with the hope to reduce the overall incidence of NAS. Some programs attempt to wean the mother off of medications, but the detoxification process can cause extreme stress to both the mother and the fetus and is associated with high rates of relapse. As such, the medication-assisted management or opioid substitution, primarily with methadone and buprenorphine, is recommended. So this slide references the executive summary of a recent joint workshop on opioid use in pregnancy where opioid substitution was extensively discussed. And the reference is on this slide. So you can see methadone and buprenorphine are compared. And methadone is a historical drug. It's been used for opioid addiction since 1974 and has been demonstrated to reduce cravings and prevent illicit use of opioids like heroin. Methadone programs are either outpatient or inpatient, but they're much more intensive than buprenorphine programs, which are entirely outpatient. Methadone programs tend to be more successful than buprenorphine at managing polysubstance abuse. Buprenorphine is a newer drug approved by the FDA in 2002 for opioid substitution. And as suggested, the major advantage of buprenorphine is that it can be self-administered, which makes treatment much more mobile and convenient, but also makes diversion a concern. The safety profile for buprenorphine is also favored over methadone. However, compliance is less successful, leading to higher rates of relapse. The overall incidence of NAS in both methadone and buprenorphine-exposed infants is approximately the same, but is much less than what's been observed in heroin-exposed infants. So how is NAS treated? Well, historically, it's been treated many ways, but primarily with administration of morphine to console the child and other medications to support other needs. And then those drugs are slowly weaned. And as you can see, the historical average length of hospital stay for these babies has been 23 days, with costs to the hospital approaching $100,000 per infant. And much of that is billed to Medicaid. So this represents a huge burden on the healthcare system. And outside of the medical costs, we have to consider the social costs endured by the mother, the infant, and the family. So there's been some new approaches to treating NAS, being very sensitive to these both medical and social costs, where we're adopting essentially a mantra of hugs before drugs, and also known as eat, sleep, and console. And so just as an example of a success story, the Yale New Haven Children's Hospital recently did a pilot study that was published, and here they found tremendous success by reducing the average length of stay from 22.4 days to 5.9 days, and the percentage of infants treated with morphine from 98% to 14%, which also, of course, reduces the overall incidence, overall costs all the way around. Similar approaches are now being implemented across the U.S. which I think will bring a significant positive future to everyone involved in managing opioid addiction in pregnancy and NAS. So the American College of Obstetricians and Gynecologists reports that more than 86% of pregnancies conceived by women with opioid use disorders are unplanned. And so pregnancy is actually a great and unique opportunity to help intervene. By offering non-judgmental assistance and acknowledging that these opioid use disorders are medical conditions, pregnancy becomes the opportunity to provide care that is needed for both managing the pregnancy and the opioid use disorder. And in doing so, we can help women become healthy, confident, loving, and effective mothers. So how can we help? It's been proposed that all women who are pregnant be screened for drugs. And that's because of the conception that drug testing is an objective tool. And I put on the slide sort of because we know that self-reported drug use is very poor. And we also know that understanding of the nuances of drug testing is relatively poor. So providers may not know what drug test to order and how to interpret it. We may have issues with maternal consent. And while patient-provider agreements are common in a pain management setting, they're not common in a typical non-pain management or non-opioid addiction setting. So as such, drug tests are most commonly just utilized today in treating in women that are being treated for opioid addiction and chronic pain. In the future, I think it would make sense to reconsider and either universal test or to consider the outcome of psychosocial and physical exams, testing at least the first prenatal visit and at delivery, potentially sometime in between, just to make sure that baby and mom are safe. So as suggested earlier, an intensive approach to treating and monitoring women who receive chronic pain therapy or medication-assisted therapy for opioid use disorders can improve fetal outcomes and reduce treatment duration. And so there's some data to support that here. Monitoring is very, very helpful in assuring compliance with therapy, particularly for buprenorphine. But in addition to drug testing, we need to include very much a comprehensive approach where the mother receives appropriate prenatal care, chemical dependency counseling, nutritional education, medical and psychosocial support, and so forth. So monitoring is a big picture approach, not just about lab testing. But let's go ahead and talk about lab testing. There are several things to think about when initiating a test, and one of the biggest concerns is how to assure that all drugs that an infant may be exposed to are detected. And I'm here to tell you that that expectation is unrealistic. Detection requires understanding of the many variables associated with drug detection, and those reflect the quality of the specimen, the timing of when the specimen was collected relative to the last use of a drug, overall drug use patterns, the specific drug and how the patient handles it, technology that's used for testing, the assay design itself, performance of that assay, cutoff concentrations, and other variables of assay performance. And so just to illustrate with these two bars, it is possible that we have two specimens containing drugs at different concentrations, but based on a cutoff threshold, only one would be, the green one in this case, would be reported as positive. So these false negatives are a major concern, particularly with random specimens or specimens that are of poor quality or when the assay specifications don't meet the expectations. So in terms of analytical technologies, there's really two primary technologies used in drug testing, and those are immunoassays or mass spectrometric assays. So immunoassays are based on monoclonal or polyclonal antibodies that have affinity for a specific chemical structure. The specificity does vary with assay to assay, manufacturer to manufacturer. Some are designed to detect several chemically similar drugs, such as a class of benzodiazepines or opioids, and others are designed to detect a very, very specific compound, such as oxycodone. In any case, assay performance, as I mentioned, will vary between specific products, and it's important to consult package inserts or labeling that come with the assay reagents to define and understand cross-reactivity profiles for the assay, which will help provide clues regarding the possibility of false positive or false negative results. Now, mass spectrometric assays detect drugs and metabolites through specific ions or combinations of ions that result from fragmentation of a drug molecule. The common technologies are coupled with gas or liquid chromatography, and so you may recognize acronyms like GCMS for gas chromatography with mass spectrometric detection, or LC-MSMS, which is liquid chromatography with tandem mass spectrometry or triple quad technology. Those aren't the only ones, but those are the most common technologies in place today. These technologies, because of the specificity of the mass spectrometer, are considered confirmatory or definitive and may be designed to generate either qualitative or quantitative results. However, the actual quality of the results and likelihood of true positive results is dependent on the assay design and specific performance characteristics of that assay. So it's important to consult with your laboratory to understand the strengths and limitations of drug approaches, drug testing approaches, and what would be the best approach for you. In terms of specimens, there are a lot of specimens that have been evaluated for detecting in utero drug exposure, and I've listed those here. They essentially reflect different times of drug exposure during a pregnancy. Some specimens are unique to the fetus or infant, which can provide clear evidence of a drug exposure when results are positive. So those tend to be the most desirable. Surprisingly, a positive maternal specimen demonstrates that the mother was exposed to the drug, but does not necessarily prove that the fetus or infant was exposed. So the fetal and neonatal specimens are generally preferred. And so I'll just run through some of the pros and cons of these based on the temporal time, the detection time anticipated for these specimens. So when we think about oral fluid or blood, we're thinking of detection within hours to potentially days, but short-term detection. So this is only going to reflect very recent drug use. Now, that could be very useful for monitoring maternal drug use during pregnancy, because testing could be performed weekly, for example. But with a newborn, we're not going to be able to collect oral fluid or blood until birth, and there's limited specimen that's available, and that short time frame is not terribly useful. So these are not commonly used for newborns. In terms of medium-term detection specimens, urine is the most commonly utilized, but sweat, amniotic fluid, vernix, and placenta have been evaluated. In adults, we recognize urine as the most common and best understood specimen. But as the pictured specimen bags suggest, collection of urine from a neonate is challenging and is not the preferred specimen, because the first void after birth, which is going to reflect the longest period of time, is easily missed, as infants may actually void during delivery or shortly thereafter, and so the specimen is unavailable. There's also analytical concerns, because some topical soaps have been shown to contaminate neonatal urine, leading to false positive immunoassays. And there have also been studies that have shown some drug metabolites are different in infants than in adults. And so typical assays, and this has been demonstrated specifically for cannabis or THC, are different. And so you may get a positive screen with an immunoassay, but unable to confirm that result with a standard mass spectrometric method. The placenta has been studied primarily in research purposes or research settings. As you probably recognize, it's a vascular organ that's responsible for maternal-fetal exchange, and so is a sink for drugs. The quantitative analysis of methadone and buprenorphine in placenta has actually been correlated with severity and duration of NAS, but the detection window is quite brief, reflecting only about 1 week of exposure, and the logistics of collection and testing are really not very well characterized. Sweat, amniotic fluid, and vernix are also used in research settings, but detection limit is reflecting 1 week or less, and routine specimen collection methods and testing approaches are not widely available. So that leads us to long-term detection specimens, which are the most desirable because of reflecting weeks to months of drug activity prior to delivery. For all these specimens, there are concerns about risks of external contamination, what the appropriate or predominant analyte would be in each of these specimens, and the appropriate cutoffs. There's really no standardized methods, and so there is variation from lab to lab. Hair, neonatal hair, typically forms at about 20 weeks of gestation and reaches the scalp about 3 weeks later, and has historically been used, but has become relatively controversial because not all neonates are born with hair. Shaving or cutting the hair can be culturally offensive, and we also don't necessarily understand the mechanism of drug incorporation into hair. So the specimen of choice really has been meconium. Neonatal nails has been challenging because there's inadequate specimen. And then umbilical cord tissue is a newer specimen that is starting to gain traction and become preferred by many organizations. And so I'll focus on meconium and umbilical cord as they really are most commonly used today. So meconium, if you're not aware, is the first stool of the newborn. It's a black tarry substance, and it's very distinctive from milk stool. It may pass within a few hours of birth, or it may take a few days. That usually passes within about 48 hours, and it may require several different collections. So this means scraping diapers and consolidating those samples, which can logistically become problematic. And in fact, mothers that know they're being watched may actually intervene and steal the meconium, discarding it. The detection of drugs depends on many, many factors, including quality and completeness of that collection, drug use patterns, and the gestation of the baby. So we know that meconium begins to form between the 12th and 16th week, and it accumulates over the remainder of the pregnancy, but that's a nonlinear process, and the actual deposition will vary. Umbilical cord forms earlier, about the 5th week of gestation, but it also grows in a nonlinear process, and so the bulk of the tissue is represented in the 3rd trimester, and so detection does tend to reflect primarily the last trimester of a full-term birth. We know that drugs appear to deposit quite consistently across the length of the cord, such that you can collect the cord at the time of birth and just send to the lab a portion of it. So this ease of collection has been the major reason why umbilical cord has gained some interest and is growing in popularity. So essentially every child has one. You can collect it right at birth. And we do know that the concentrations of drug analytes in cord are much lower than meconium, which means we have to adjust our methods to accommodate that. So we may be looking at things in the picogram per gram range, whereas meconium would be in the nanogram per gram range. So the assays are evolving over time to improve detection. The actual analytes of interest may also be different, and so assays again are evolving to reflect the best possible detection approach for these specimen types. So based on what we know today, the major advantages of the two specimens are summarized on this slide. With meconium, we've got more drug there, so it's easier to find. There's absolutely no debate about the child being exposed because the meconium is inside the child, and there's a substantial amount of research to support interpretation. With the cord, as I mentioned, all infants have one, and there's plenty of specimens that can be sent to the lab right at birth, which facilitates time to result, which is very desirable because infants that are released from the hospital before the symptoms of NAS appear may be lost to follow-up and may not get the care that they need. Another advantage of cord is that it avoids detection of drugs that are administered directly to the infant after birth. And we have found that cord results tend to be less discrepant in twins and triplets than meconium. And that's really because of the logistics of collection, where you get the cord right at birth, whereas the meconium comes when it comes. And so in a multiple birth situation, the collection may be better for one twin or one of the children than the others. Some of the disadvantage of the specimens, as I mentioned, collection is the major disadvantage for meconium, and also specimen availability. With cord, we know that we may not be as sensitive for all drugs, and that's really a reflection of understanding what concentrations we need to be at to accurately detect drugs of interest. Both specimens suffer from heterogeneity, particularly with premature births. They both suffer from risk of contamination. With meconium, you can get contamination from the infant urine, and with the cord, you can get contamination from the maternal blood. So those are risks that have to be accepted. We also know that no lab test is perfect, and so negative results do not exclude the possibility of exposure, and that there's no standardized methods or cutoffs. So knowing that tests are now available, although not standardized, the question arises as to whether this kind of testing is mandated in the U.S., and the answer is no. Although the 2010 Child Abuse Prevention and Treatment Act, or CAPTA, does provide federal funds to states to help support investigation, which could include laboratory testing. And the 2015 Protecting Our Infants Act requires the Department of Health and Human Services to review the activities around prenatal opioid use, including the incidence of NAS, which is part of the reason that we have some nice data coming out. Now, deciding who, how, and what to test is another issue. What we know is that testing criteria need to be unbiased as much as possible. There needs to be a cause to test or universal testing. Universal testing is not common right now, but instead most facilities will first of all consider their local or state policies and then evaluate risk of exposure. And so evaluating risk requires establishing questionnaires or criteria regarding prenatal care or the presentation of the mother or the child, and then collecting specimens. Now, some facilities are collecting specimens from all births and only submitting the specimens that reach the high-risk category, then storing low-risk category specimens until the baby has been monitored for signs and symptoms of NAS or other concerns that may make it appropriate to pursue testing. So what are some of those risk factors? This is a list of some examples of risk factors related to mother and newborn. So they're actually quite logical. Mothers who have a history of drug use or abuse in a known at-risk environment, a history of high-risk behavior like prostitution, mothers who present with placental abruption or unexplained premature labor, and teenage moms have historically been at higher risk. Also, newborns that present with unexplained neurological complications that are very small at the time of birth or have signs and symptoms of NAS also fall in that category. But this list is associated with fairly limited evidence-based research. So I wanted to quickly share an experience from the University of Iowa that they've published recently to evaluate the diagnostic yield of these and other risk factors. And so they did a retrospective analysis of their practices and an extensive chart review for all positive drug tests, and this included meconium and urine samples. And what they found is essentially no utility of urine, very low positivity rates, but a very good utility of the meconium, wherein almost 70% of positive results could be explained by just maternal history of non-medical drugs. 51% could be explained by maternal history of tobacco use. And so when you combine those two risk factors, you could actually explain almost 91% of the positive samples, meaning that a lot of the other risk factors didn't have a very strong diagnostic yield. So once you have results, it's important to evaluate those results relative to pretest expectations. So are you expecting a particular drug? Yes, and you got a positive result, then all is good. Proceed with your local policies and procedures. If you got an inconsistent result, meaning an unexpected or an unexpected positive result, then it's encouraged that you consult pharmacy records, discuss the testing and associated results with the laboratory, and also approach the mother to help reconcile those results. So some of the common questions that, that I've seen relative to interpretation of results are, can first trimester exposures be detected? And the answer is no. And that's related very much to this nonlinear process of specimen accumulation. And so there's a strong dilution effect of anything that happened in the first trimester, or there wasn't any real specimen there to begin with. Are drugs administered during labor and delivery detected? And the answer to that is also yes. And that's reflected actually by data on this slide, where we had a history of maternal prescription for morphine, as well as a known infant prescription, and we saw positive results for morphine, as well as hydromorphone, which can be a minor metabolite of morphine. Hydrocodone is probably unrelated, but in any case, yes, drugs administered during labor and delivery can, not always, but can be detected in meconium or in umbilical cord tissue. Regarding the next questions, common questions, which I know you can't see right now, but related to whether the source drug can be determined and whether a negative result indicates the drugs weren't used. To study that, we looked at concentrations of morphine and common related opioids, 6-monoacetylmorphine, which is the metabolite of heroin, hydrocodone, hydromorphone, and codeine. And so this question comes up quite a bit about heroin detection, where a mother has admitted to heroin use and the lab doesn't find the 6-am metabolite. And so what we did with the data on this slide is look at results from about 75,000 patients and analyzed the patterns of when we observed 6-am. And so when we observe 6-am, we see morphine concentrations that are very, very high. We also see hydrocodone that's quite low. And then hydromorphone, which again is a minor metabolite of morphine. And codeine, which is an impurity of heroin. And so this is a typical pattern that is observed even in the absence of the 6-am and can provide supporting evidence for use of morphine or use of heroin when that 6-am metabolite is not found. So in thinking about why 6-am isn't often detected, we also performed a stability test for 6-am, and what we found is that 6-am is relatively unstable. And so within 2 weeks of spiking, we lose about 50%. Considering that the general concentration is around 11 nanograms per gram, which is often close to a cutoff of 10 nanograms per gram, it's very likely that 6-am will be missed by most laboratory tests. And that is evidenced also by the rare positivity rates that have been seen. So it suggests that we need to do something different with our tests, and that may be increasing the sensitivity of the tests, lowering those cutoffs so that we can capture it, using other biomarkers of heroin use, perhaps using different specimens. And one of the other things that relates to this is questions about synthetic opioids, such as fentanyl analogs and pink or U47700, which are now being used in many places around the country, often as heroin substitutes, but are not picked up. So we have babies that are presented with NAS, and we don't find any drugs to really explain that, which can be very frustrating. This slide addresses one of the other questions relative to the content. So cutoff concentration is important. In this data set, there were authentic samples that were positive for cannabis or THC using an immunoassay that had a cutoff of 1 nanogram per gram. We then analyzed them by a mass spectrometric method that looks at 4 different analytes of cannabis. So the parent THC, the 2 metabolites, 11-hydroxy and 9-carboxy, and then a cannabinol. And what we found is that there was one sample that was positive for ELISA, but actually didn't contain any of the traditional analytes. Instead, contained only cannabinol, which is not thought to be psychoactive, and so might lead to inappropriate interpretations. We also saw a number of samples that were positive by this mass spec method, but were negative by, this is an example here, negative by the ELISA, but positive by the mass spectrometric method. So the take-home message is that content and cutoff concentrations can make a big difference in terms of positivity. And getting a negative result doesn't necessarily mean that there was no drug exposure. So now I'll show you a little bit of data from laboratories that have converted from Meconium to cord, or at least considered it with an evaluation of the 2 specimen types head-to-head. And so this also comes from the University of Iowa, where they actually saw very similar positivity rates for the 2 specimens, but they notably found that the distribution of positive results was different in the cords and the meconium, so where the cords actually seem to be more sensitive to oxycodone than the meconium, and the Meconium was picking up a number of the medications that are administered directly to the newborn, such as codeine, morphine, lorazepam, and phenobarbital. So this actually really confounds the interpretation of the results, because you don't know for sure whether the baby received these drugs, and that explains the result, or if the mom received the drug in addition to baby receiving drug. Here are data from Vanderbilt University. They published a paired result study for cord and meconium, where they found in 217 newborns that there were 114 discordant results. And so what I want to highlight is that sometimes the cord is positive, sometimes the meconium is positive. Sometimes both are positive, but for different analytes. And so the specimens, even though they both are thought to reflect drug use during the last trimester, do have differences in terms of sensitivity, and the laboratory methods are going to contribute to that as well. So in the case of Vanderbilt, they concluded that the cord collection was logistically preferred, but that they did not choose to switch and stuck with their meconium, which they were more comfortable with. Here, a study that was recently published from Ohio State University showed very good negative agreement and mixed positive agreement. What I think was most notable is that they found their clinical sensitivity for NAS was improved with cord, but that there were still a number of babies with NAS diagnoses for which both meconium and cord results were negative. So in their case, they chose to switch to cord because of the logistics, but they also recognized that not everything is going to be detected, and that we still have room for improvement in monitoring these babies. So this risk of false negatives is the biggest concern, and so it's important to consider the specimen quality, the drug use patterns, the stability of the drug analytes, and the performance capabilities of the assays when interpreting results. So regardless of drug testing results, you don't treat the result, you treat the patient. And neonates with NAS need to be monitored after birth to minimize the likelihood of long-term consequences, such as those shown on this slide. And mothers also need to be monitored. Unfortunately, it's been shown that discontinuation of opioid substitution therapy and relapse is relatively common within the first 6 months of birth. So maternal urine drug testing is recommended to assure adherence to the opioid substitution plan and abstinence from non-prescribed drugs. Adequate pediatric care is also very important to monitor, and it's time to have that discussion about whether or not to breastfeed. In general, breastfeeding is encouraged for mothers that are adherent with methadone and buprenorphine therapy because there's very little of those drugs that appears to get into the breast milk. But concerns may arise regarding other drugs, especially use of illicit and non-prescribed drugs, chronic alcohol use, or other indicators of aberrant drug use. So fortunately, there are guidelines about breastfeeding. This 2015 guideline makes recommendations specific to individual drugs and promotes the use of breastfeeding for babies that are exposed to methadone or buprenorphine, or mothers that are treated with those drugs. Whereas the mothers that are known to use cannabis or THC-containing products are discouraged from breastfeeding because the THC tends to concentrate in the breast milk itself. So this seems like a contradictory statement. Some drugs are okay, some drugs are not okay. And in fact, these guidelines are based on extensive research to understand how drugs are transferred into the milk and with what efficiency. We know that some drugs are trapped in the breast milk due to the pKa or chemistry of the drug, binding of the drug to proteins or lipids in the breast milk. We're also aware of changes in drug transporters that can influence transfer of drugs into the milk. There's been enthusiasm to measure milk plasma ratios, and in particular AUCs, or area under the curve, but we now know that drug concentrations in milk do not change in parallel with drug concentrations in plasma, and pharmacokinetic models have been developed to incorporate everything we can know about that drug transfer into the breast milk to evaluate the appropriateness of breastfeeding for that infant. What we have to remember is it's not just about how much gets into the milk, but about how much milk the baby drinks and what the size of the baby is. And so one of the things that's been interesting is that it's been demonstrated that accumulation of drugs is more relevant than an occasional use of drugs, such as, say, a course of antibiotics. So I encourage you to consult the Academy of Breastfeeding Medicine guidelines, as well as this very informative and easy-to-use website called LactMed, which is a drugs and lactation database hosted by the U.S. National Library of Medicine. And it's peer-reviewed and updated monthly. It provides references for all of its recommendations. It provides information on the concentration of drugs and drug metabolites that are anticipated in the breast milk, possible adverse effects of nursing, as well as therapeutic alternatives for drugs of specific indications. So it's a great resource. So with that, I come to my conclusion slide. And so pain management is important in pregnancy because pain may actually intensify with pregnancy, and we need to treat the patient. We need to manage that pain, prevent withdrawal when there's suspicion of addiction, and consider the impact of drug therapy on the fetus as well as subsequently on the infant. Urine drug testing is an important tool for monitoring drug adherence during pregnancy and lactation, whereas meconium and umbilical cord are the preferred specimens, although not perfect. They are the preferred specimens for evaluating drug adherence with buprenorphine and methadone, as well as for detecting use of non-prescribed or illicit drugs. The drug testing results have to be interpreted based on the maternal and infant history, as well as strengths and limitations of the associated specimen and the analytical methods. So thank you for your attention.
Thank you, Dr. McMillin, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the green Q&A button at the lower left of the presentation window, type your question into the box that appears on your screen, and click the send button. We'll answer as many of your questions as we have time for. So let's get started with our first question. Our first question asks, is it recommended that breast milk be routinely tested for drugs?
So there are not any specific guidelines related to testing breast milk. There are laboratories that offer breast milk testing, and if there's a good reason to test the breast milk, such as a serious and suspected exposure, it may be appropriate. However, breast milk represents only a few hours since drug exposure for most drugs, and so it will really only reflect very recent or daily use of drugs. Breast milk is also challenging in that the concentrations of the drugs may be different in the foremilk, hindmilk, and other portions of a feeding. So if one is going to test breast milk, the preferred approach would be to collect an entire feeding and mix that and then send that in for testing. Relative to interpretation, as I mentioned earlier, you need to really think about how much milk the infant consumes relative to the infant's weight when looking at the concentrations. So interpretation is really challenging, and I wouldn't routinely recommend it.
Thank you for your answer. Our second question asks, when is chain of custody required for drug testing?
So chain of custody is a forensic or legal document that authenticates every step of the process from specimen collection to destruction. And so it's very important to use a chain of custody if a result is going to be admitted as evidence in a criminal court system or other forensic proceeding. For most of the testing associated with detecting in utero exposure, forensic processing is not required because the purpose of testing, the whole reason is medically based, to manage the patient, treat the patient, provide the care necessary for the mother and the infant. Sometimes medical testing results are utilized for, say, child custody scenarios, which are usually heard in a civil court system. And in my experience, chain of custody is not routinely required as long as the policies and procedures that the hospital and the laboratory have for specimen collection, handling, and testing are followed.
Thank you. The next question asks, should drugs other than opioids be included in a drug test intended for chronic pain patients?
So opioids have gotten most of the attention, and that's likely because of the opioid epidemic that we've seen in our population in general, which has now bled into the pregnant population, and the association of opioids with the NAS. However, other drugs are important. Other drugs can contribute to the onset and severity as well as duration of NAS, and so it is practical to test for other drugs. And it's not feasible for most labs to look for any possible drug, and there really aren't any guidelines to dictate the content of an assay. So most laboratories choose to offer panels that include opioids, sedatives like benzodiazepines and barbiturates, stimulants like amphetamines and cocaine, and cannabis to cover commonly controlled, prescribed, and illicit medications.
Thank you for your answer. We have another question. This one asks, what testing is available to detect the various classes of designer drugs on the street or available through the internet?
So that's a good question, as we have seen an infiltration of synthetic opioids, synthetic stimulants, synthetic cannabis. Lots of synthetic or designer drugs are now on the street and widely available on the internet. In some cases, an immunoassay, such as one performed in a hospital laboratory, will cross-react with a synthetic drug, leading to a positive result that can help guide care of the patient. But in most cases, the synthetic analogs are undetected by the traditional testing, and in fact, most of emergency rooms are going to treat the patient, not the test results. So unfortunately, they're not easy ways to look for all of these designer drugs. There are specialty toxicology laboratories that are probably your best bet at identifying those unique drug compounds.
Okay, thank you for your answer. We have time for one more question today, and the final question asks, is it appropriate for a clinic to perform urine drug testing with a home test or otherwise commercially available dipstick or cups? Yeah,
so you may have noticed kits that you can purchase either at local drugstores, grocery stores, and on the internet that are promoted for home testing. Similar products for testing that are either essentially urine collection cups that are embedded with immunoassay strips, or dipsticks themselves are available for purchase in bulk that are very, very tempting to clinics because they're affordable and you get a result very, very quickly. But I would caution any clinic that's considering these types of tests to read the labeling and understand the regulatory implications of that kind of testing. Testing is classified in the U.S. based on complexity, which influences your regulatory requirements for the people that perform the test, for the licensure of the clinic itself, and for any subsequent testing. So if the test is considered waived, which would mean that it's of the simplest complexity and appears to be exempt from a lot of the CLIA or other related regulations, be cautious and look at that labeling, because most of those labels require that any positive result be confirmed by a GCMS or LCMS-MS type method, which could lead to pretty expensive consequences if the likelihood of positive results is high, which it usually is in chronic pain patients. So it may not be appropriate, and I think I would caution you to look at the details that are associated with any test that's implemented in a clinic setting before pursuing it and subsequently billing for it.
Thank you, Dr. McMillin, for your time and for your presentation. I would also like to thank Laboratories for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through February of 2018. You will receive an email from Laboratories letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thank you for joining us, and we hope to see you again here soon at Laboratories. Goodbye.